So in certain situations, an external device is not suitable. So patients end up with a port, which is just a central venous device that is completely implanted beneath the skin in a little pocket. Um, it is an indwelling catheter, or has an indwelling catheter attached to it. It's surgically implanted beneath the skin with the catheter tip that lies in the superior vena cava. Um, the catheter is threaded through the subclavian at the shoulder or through the jugular vein at the base of the neck. You can also have an implanted port that's suitable for an epidural, an intra-arterial, or an peritoneal placement. Too many P's in one place. So implanted devices seem to be much easier to maintain than external devices. They do require heparinization about once a month to maintain the patency if they're not used on a regular basis. They have less risk of infection because there's no exit site, so that the microorganisms can't get in there that way. And they have several advantages for the patients, being that there's minimal activity restrictions, few self-care measures to learn or perform, and then few dressing changes except when it's accessed and used to maintain. Implanted ports then create only a slight protrusion under the skin unless the patient is a very, very thin patient. If the patient is extremely thin, then a lot of times they do have a little bulge that is visible from the outside. Patients are more accepting of an internal device than they are an external, because like I said, that most of the time it is not visible. With an external or internal device like a port, though, they can still shower, swim, exercise, and they never have to worry about the device because it's not accessed. It is determined by the practitioner how long after the implantation that they can do all of these things again, but that is an advantage of it. Because it's positioned under the skin, though, it is a little more difficult for the patient to manage, especially with daily or frequent infusions, and it requires insertions of special needles through the skin, and it may be uncomfortable for those patients if they have a fear or dislike of needles. Implanting and removing the port requires surgery and possible hospitalization, which can be costly, so that's one of the disadvantages. Ports are worthwhile for anyone who requires an infusion therapy of at least 6 months. So that is one of the advantages. And also, ports must be accessed via sterile technique. Okay? I went the wrong way, sorry. So anytime that your patient has a port or any kind of central venous access device, you need to make sure that they understand the procedure itself for implantation of the device, the benefits and the risks, how this is going to require them to care for it themselves, and then make sure that their questions are answered. They need to know, are there any movement restrictions? Are there any cosmetic concerns? Or are there any management regimens like flushing with the heparin for the port? They also need to make sure that what the sterility is, if it's a clean procedure or a sterile procedure. Any positioning, because ports are sometimes very finicky and patients must be in a certain position, like an arm over their head or leaned back, or a leg up, or sometimes they need a cough or something like that for a port. Sometimes they do experience some stinging sensation or a feeling of pressure. Excuse me. When the port is being accessed, because it is a needle puncture through the subcutaneous skin. And then they need to understand dressing changes, when a dressing change is required, and how it must be done, and then the flushing procedure and protocol as well. So those are all things that the patients have to be taught for a port. So if a patient does get a port post-insertion, respiratory status has to be monitored if it's near the subclavian or the IJ vein. Okay. Dyspnea, shortness of air, and sudden chest pain are all big red flags that patients need to be aware of, and you as the nurse need to be aware of for people who have just had a central venous access device inserted. So cardiac status as well. If the catheter enters the right atrium or the right ventricle, there is a possibility of arrhythmias, and you must do a radial pulse check if there's no cardiac monitor on them. Any type of device should always have a chest x-ray post-procedure to ensure that the tip of the device is where it is supposed to be. So you make sure that your patients have that ordered, and that they get that, and that those x-rays are looked at. So dressing changes I mentioned just a little bit, and I'm trying to get you on the right page here so that you know where we are. Dressing changes, 102 should be where you find this information. Okay. Actually, it's on 107 for specific dressing changes. Like I said, it is a sterile procedure. You do have to wear gloves and a mask. If the patient can tolerate a mask, then you have the patient wear a mask as well. And that is so that while they're talking to you, or you're in there and you've taken this dressing off of this, that if they cough or sneeze or anything else that is contained within the mask and is not a source of infection for their central venous access device, then so when doing a dressing change on your patient, if they have a gauze dressing, it's going to be changed at least every 48 hours. If it is a transparent dressing that you can see the site through the dressing, it's only every 7 days. Any dressing that is moist, soiled, loose, or has compromised integrity has to be changed immediately. So they can be done as needed as well. So when you flush a central venous access device, it has to be done with saline on a routine basis. You have to know what your facility's policy is to maintain patency. It's just like a regular IV in some respects, that if you put an antibiotic through it or some other kind of solution, that you're going to flush with saline afterwards, or if you give a medication, just a push of something, that you're going to flush with saline before and saline after as well. Sorry, I'm having sneezing problems, you guys. But it does depend on the catheter type and the medication schedule and the medication that's being used for it. It does require heparin. And we're on page 110. Heparin usually comes in vials that you have to draw up. And facilities have certain protocols for heparin flushes as far as how much you're supposed to use, and sometimes the docs have a preference too. So you have to know what that policy is, or you have to know what the order is that is written. In certain cases, like a Grishong, heparin's not necessary. You can just use the normal saline to keep the line open. And the flushing varies from what kind of device it is, from every 8 hours to just once weekly. Usually they recommend 3 to 5 cc's of solution to flush it, but some places do prefer 10. And you have to be aware of the size of syringe to flush it with also. Remember we talked about that a 10 cc was recommended for a PICC line because of the pressure. So you do need to know, based on the device, what the manufacturer's recommendation is for the size of the syringe as well. You have to make sure that the caps are changed on those devices. According to facility policy and how often the cap is used. It's usually recommended that it's about every 7 days that caps need to be changed. Any time that you are using any central venous access device that does not have a continuous infusion going through it, you're just using it intermittently to push a medication or to hang some kind of medication or anything, you are to clamp that line. You clean that cap, that port, and you connect whatever your syringe is or whatever your tubing is to it, and then you unclamp it. You never connect without clamping that line first. Okay? And that goes for changing caps as well. Anytime you use a line, you're going to clamp and then clean and then connect for any reason. Okay? When you draw blood from a central venous access device, of course you always wash your hands and you put on your gloves. You're always going to clamp the device closed, clean it, and you're going to withdraw 10 cc's of blood. Some facilities now only do 5, but you're going to withdraw those 10 cc's of blood. You're going to clamp that line again, and then you're going to throw that blood away. You always aspirate 10 cc's, 5 to 10 depending on facility policy, of blood, which is discarded, before you draw any other blood out of that line. This is so that any blood in that line is not contaminated, so to speak, with anything else that has been recently put into that line, that it's a good, clean sample from within the circulatory system rather than something that's in the line. If you do not withdraw that blood, aspirate that blood, and discard it, you are drawing up whatever's in that line along with the heparin or the saline or whatever medication it was that is in that line, instead of a true sample of what's in the circulatory system at that moment. So just remember that. And you clean, clamp, you aspirate, you clamp, and you discard before you do anything else. And then you connect your new syringe, you unclamp it, you aspirate whatever amount of blood that you need, you clamp it again, and then you remove that syringe. And then you, if it's a 10 cc syringe that you have and you need 20 cc's of blood, well, you've clamped it and you've removed it, so you're going to clean that port again, you're going to connect that new syringe, you're going to unclamp it, you're going to withdraw what you need, you are going to clamp it again and disconnect that syringe. And I always, as a habit, I always wipe it off even after I disconnect it, just as a good measure, I guess. And then when you're done with it, you're going to flush with normal saline or heparin, depending on what the protocol is. And the amount is going to be based on your protocol also, your facility protocol. But just remember that. You always clean, you always clamp, and then you connect anything that there is, okay?